All right, so that's basically the slide that I just spoke on now. So with regards to bone conduction hearing devices, they can either be surgically implanted or be non-surgical. So with regards to this not surgically implanted, they are divided into two. We have the percutaneous, which there will usually be an abutment that is penetrating through the skin, and then there'll be transcutaneous devices, which the implantable device does not penetrate through the skin. So there'll be a magnet, an internal magnet, and then either an external magnet or the processor itself. And that's where then you get the passive and active transcutaneous implant. This is just a visual view of the transcutaneous passive and active versus the percutaneous. Are my slides changing now?
So you're still on your third slide. I think if you just keep clicking on the your smaller slides on this side, they'll change.
I don't have just, I'm not sure. I don't know how I can get the slides to move with me,
So if
because when I go to my share screen, I get three options where I can either share the tab, the window, or the entire screen.
so then you should probably just share your entire screen. But there's a setting there for advanced options on the
I
side.
don't have that. Maybe it's because I'm using the browser, not the
Okay.
app.
So then what you can do is just share your entire screen and then you can just manually click the slides as you talk through them.
It doesn't allow me to share it. It's just an option that's there, but it actually is not sharing. Okay, there we go. Let's see if this one works. Is the slide changing?
Yeah, it's changing now.
Great, thank you. So I was saying that this is the visual presentation of the transcutaneous active versus passive, as well as percutaneous bone conduction hearing devices. So with percutaneous, you usually have, like I said, an abutment, and the processor then would be attached to the abutment that is penetrating through the skin. With the passive transcutaneous, you have two magnets, and a magnet inside internally and an external magnet, and the processor will attach to the external magnet. And with an active transcutaneous, then there's only the internal magnet, and the processor um, directly links to that internal magnet. With regards to the advantages of the percutaneous bone conduction hearing aids, they can be done in a single stage procedure and under local anesthetic. However, people can have skin reactions and more prone to device extrusions, and sometimes you might need to have revision surgeries where you need to insert the abutment because there's been complications around it. Passive transcutaneous devices have less skin complications, however, because there's two magnets. The force of those magnets can cause skin irritations, and because there's soft tissue between them, that can dampen the sound signals. And you find that sometimes the people will present with skin seroma, hematoma, wound infections as post-operative complications. Whereas the active transcutaneous devices, what it takes is the advantages from the passive and the percutaneous, and it maximizes on those benefits, ensuring that skin complications are avoided. There's soft tissue attenuation is not as prominent. Okay, now we're looking at what Groote Hospital has. As we've already spoken about the disadvantages of the percutaneous, we are leaning more towards the active transcutaneous devices. So previously people were being fitted with the percutaneous Oticon Ponto on abutment, but now we're basically just, only replacing the processors for the people who already have the abutments on them, and sometimes it transfers from Red Cross who already have abutments, so then we'll replace the processors where it's needed to do that. We have the bone bridge, which is the active transcutaneous, and we are using that for our newly referred patients, or that's the option that we consider first for them if they need a surgically implanted device. And for those that can use a non-surgical device, there's a thing called transcranial cross hearing aid, which is less expensive. There's less complications that the patient has to deal with, and it's also available to newly referred patients, and as well as older patients who might be candidates for it. So how that works, it basically uses crossover hearing from your bad ear to the good ear. So it's basically using the cochlea of your good ear. And just looking at expanding on the candidacy criteria, for the people who we're looking at a bone bridge for them or a surgically implanted device. We're talking about people who cannot wear conventional BTE hearing aids because maybe there's malformations, microtia, atresia, or they have chronically leaking ears, so they just can't keep a hearing aid in their canal or an ear mold in their ear canals. We're looking at conductive hearing losses, mixed hearing losses, and sometimes single-sided deafness. And also something that's very important to consider for these patients is that they should actually be medically fit for surgery, and it's something that they actually don't have a problem with going through. And for purely the single-sided patients who have normal ear anatomy and, there's no middle ear or retrocochlear pathologies, then we will be looking at the transcranial cross hearing aids. Like I said, it's a much cheaper option. There's less complications attached to it. Then the bone bridge, when we're just looking at the audiogram, what's very important is that the bone conduction thresholds do not exceed 45 dB. your air conduction thresholds, this is in the ear that we are interested in implanting. Your air conduction hearing air thresholds can be at any point in that gray area. And if it's a single-sided deafness person, the good ear has to be strictly normal, and then the affected ear or the bad ear can be anywhere between severe to profound. However, then when it comes to the transcranial hearing aid, as much as the ear can be profound, but here we are looking at evidence of crossover, which is basically the shadow curve audiogram, which would usually be a reflection or the unmasked thresholds that reflect the response of the cochlea of the good ear. So you need a present unmasked thresholds at all frequencies, and those do not cannot exceed 85 dB, because the receiver strength for the transcranial hearing aid is 85. And also very important, the word identification scores do not have to exceed 60%. This makes them more likely to benefit from the device. And then something that we debate a lot about in our team discussions is finances. So I'm going to speak a little bit more here. And I'm also going to be talking numbers just to give you an idea of why, if you are looking at a potential candidate, you should be considering the finances, and why it's something that is very, very important for us to consider when we are looking at these candidates. So just off the bat, you need to know if this person and this patient has financial support. And what we mean with, about that is, this a working individual? Are they working full-time, part-time? Is it a scholar or a student that has unemployed parents, or they have unemployed parents? Or are they on a social grant? Are they on a DG, so those are things that you look at, because it kind of gives you an idea of where they are, or where they potentially are financially. And when we're looking at the device costs for the devices that we have here, I'm going to speak particularly to the bone bridge and the transcranial hearing aids. Starting off with the bone bridge, the cost of the processor itself is 50,000 rands. So the hospital has a classification of for the patients. So you either classed as HO, H1, H2, H3, and private. HO, you don't pay usually for any of the services that are being offered, as well as the assistive devices. H1, you pay 10%, H2, you pay 20% of the assistive devices, so of the actual cost of the device. So you need to be thinking that, is this a person that will be able to afford 10%, 50,000 rands? Should that bill be sent to them if they are fitted with this device? And also, with the bone bridge, the there are covers that need to be changed every 3 months. Otherwise, if not, then the quality of the sound that the patient is receiving is impacted. So then the patient needs to kind of be aware that in a year they're going to be spending about 1,200 rands to 1,600 rands on just covers, and then there's also batteries for the device. So these are basically costs that are attached to the bone bridge, and that if you are thinking of referring a patient, you need to keep that in mind, that there will be these costs that this person needs to be able to afford. And then with regards to the transcranial, patients need to have a custom-made RIC mold. and for the trial. So this is an upfront payment that they need to be able to make even before they know if this is a device that they want, and they, it actually makes a difference in their lives. And once then they've gone through the trial, they want the device, then they're looking at again paying 10% or 20% of the actual cost of the device. They're looking at work guards, replacement of the rig mold itself, should it be damaged due to moisture or just general wear and tear. And for the rig mold itself, they're looking at about 1,000 rand. And there's also again batteries. As we stand here at the hospital, we do not have a repair budget for any of our assistive devices. So this means that any of our patients need to be able to pay for their own repairs. Should the device, something go wrong or it breaks and the device is already out of warranty, then the patient needs to be able to pay for either the replacement of the device itself or the repair costs. So this is why it's important that we look at the finances, because if the processor, a brand new processor costs 50,000 rands, and then we know that the repair costs will be as hefty as well. Sorry, excuse me. So yeah, we are basically avoiding a situation where we have people with either implants or abutments, and they're just sitting at home with no processors because they are unable to afford maintenance costs or repair costs. And from a social perspective, basically, we want to look at the fact that if we are giving this device to this person, is it something that is actually going to come in and improve their current circumstances? Or is it just going to continue to make their lives a little bit more complicated? And we attach that to the financial part of it because of the maintenance that is related to these devices. And we're also just looking at the communication demands or needs for this patient. Is this a person that is struggling only in social situations, that they find themselves once a month at a social, at a family gathering, but on a daily basis, they're just on their own, spending time alone at home? Or is it someone that is actually out there working as a receptionist, for example? So, what are these patients' communication needs? And then just moving on to the referral process. So you kind of know at this point what Grooteskier has to offer. And if you have a potential candidate, what are the things that you should be looking at? The type of hearing loss, which device would be suitable for them, the finances, and also just a social perspective as well. It is your duty to provide the patient with as much information as you possibly can from what you know about the device, about the potential device that you are referring them for, and ensure that the patient actually wants this. And if it is a surgically implanted device, you also want to establish that this is a person that wants to go through a surgical intervention, and they are aware of that it actually is a thing that will be coming with this device. And then you need to fill in the referral form. But before you even get to that, I think explain the process, the potential process, which I'll get to in the next two slides. But just explain what the potential process they are looking to go through should the referral be accepted, be sent, and what they might be looking at. Because when you send a referral, when a patient is dropping off a referral, there isn't always an audiologist who can sit down with them and speak to them. So we want to equip you as well to be able to have that conversation with them, just basic, and so that they are at least aware of what they're getting themselves into. They know what they should be expecting, or they kind of have an idea of what to expect along this journey. And this is the referral form that we have. It's a new one. You might have one from a long time ago. Please delete and discard it. I will be distributing this one via email, and there will be copies at ENT and Audiology OPD. We please ask that you give as much detail as possible to this referral so that we can have something to discuss at the meeting. And now this is just a potential process that a candidate would go through. Okay, it's not always exactly the same for everyone, but this kind of just gives an idea because you need to explain to your patients, right? So this is basically what you would kind of highlight to them. We will receive the referral letter, and we will have a team discussion, which usually happens on the first Wednesday of the month. And from there, then we will look at, does this patient need further assessments, or which device would be more suitable for them based on their hearing loss and the information that you have provided us with. And then move to, okay, let's start a trial with them with that device that we think would be best for them. Patients would go through a trial for a month for both the devices. And in that trial period, it's to basically for them to see if it actually works for them. Does it make a difference in their life and communication? And we also look at how well they take care of the device during that time, and also are they actually using the device during the trial period. And then there will be then another discussion, which is stage 4, which is basically the decider. So the patient comes back at the end of the trial and they're like, okay, I do want this device. It's actually making a difference in my life. And if it's a surgically implanted device, and we also then have a team discussion with all the information that we have from the patient and from our observations as well. Then if they can go ahead, then we move on to the pre-counseling. Then they have the surgery 3 weeks after the surgery, or to 4 weeks, depending on how they are healing. Then the switch on will happen, or the fitting of the actual processor will happen, and then we will follow them up as per protocol. And for the transcranial cross hearing aid patients, they jump from stage 4 straight to stage 7. So if the patient comes in and they like, I like this device, it's actually making a difference in my communication, I want it, we immediately fit them with a new device and follow up as needed. But then there's the people who come in and they're like, no, this is not making a difference, or I actually need time to think if this is something that I truly want. Then we will see what further management is best suitable for that patient at the team discussion. Um, Basically, at the end of my talk, and basically to summarize everything, we have the surgical option, which is the bone bridge, and we have a non-surgical option here at Grotescare, which is the transcranial cross hearing aids. These devices both are very, very limited. We only get about 5 a year. So this is also why the criteria itself is very strict. So it's very important to consider your patients holistically. Look at, is this something that is, look beyond the hearing loss, basically. Is this something that is going to make a difference for them, or is it just something that is going to be a burden in their lives? And very importantly, refer accurately and with as much information as possible. Ensure that the patient actually wants this and is aware of what you are referring them for. Okay, timekeeper, do I have time to get to the team to the case discussions, or should we move to any questions?
We can proceed with some cases. Thanks, Yamila.
All right. Thank you. So I'm just going to be talking up just a few cases that we have, just to kind of put into context everything that I've just said, And so, when you do have a case in front of you, maybe it would help you to decide or know how to refer and which processor or device you should be referring for. So, first case, this was a 24-year-old. She's unemployed and has had a long-standing conductive hearing loss. She generally struggles with communication. She had finished her matric but didn't continue with her studies, even though she really wants to. But she struggled to get through school because of the hearing loss. So she kind of took a pause to find out what her amplification options are so that she could better equip herself when she continues with her studies. She's got employed parents, both of them. They're very supportive, as well as her older sister. This patient was referred for a bone bridge, which she we decided to fit her with it, and she was implanted on the left ear. So if you're just looking at the audiogram, the bone conduction hearing thresholds do not exceed 45, and therefore that makes her an ideal candidate for the bone bridge. And because of her chronically leaking ears, she cannot wear a conventional hearing aid. And she's got a good financial support system, and it's her parents and sister, and she's got plans for her future. So this is someone that actually wants to improve her life, but the hearing loss itself is hindering her from doing that. So the implant then is going to come and make a change in that family. Hence, she was considered a good candidate for the bone bridge. And then we had a 15-year-old boy that was referred for a transcranial cross because he has single-sided deafness. His dad works, and he's in a mainstream school. He struggles at school, but his report was very good, showing that he's working hard listening in class. We did a transcranial assessment, and unfortunately, he did not meet the criteria. So his unmasked thresholds, sorry not for not having them here, but we're beyond 85 dB from 1000 hertz. And also his speech scores were poorer than 60%. So then we actually decided to fit him or implant him with a bone bridge, because we know how mainstream classes can be huge. So this boy really needed assistance with regards to his listening so that he can continue performing well at school and has better chances of generally just succeeding at life. His dad working also gives us assurance that they will be able to afford maintenance of the device. And then we have a 25-year-old jeweler who was fitted a few years ago with a percutaneous Baha. He had the apartment. His processor was working well. He's taken care of it over the years. However, his biggest problems was that he kept having infections around the apartment, and he has had multiple revision surgeries where the apartment was taken out and put in again. And so this just made him have constant pain and pressure sensation around the apartment. And oftentimes then he was not wearing the processor, and he would struggle with communication in noisy situations. So the decision with this patient was that we extract the apartment. We did a transcranial assessment with him. He met the criteria, and therefore he was changed to the transcranial cross hearing aid, and he is very much happy with that option over the percutaneous Baha. And second last case is a 54-year-old domestic worker. She's also got a long-standing mixed hearing loss. She's got mastoid cavities both sides. She was initially started on conventional hearing aids, but whenever she would wear the hearing aids, her ears would start leaking. So she couldn't really use the conventional hearing aids, and also was implanted a few years ago with the percutaneous Baha. She's very happy with it. She's still coping quite well, and her communication has also improved. Last one. This is a 48-year-old that has a long-standing unilateral sensory neural hearing loss. She's a housewife, but has a supportive working husband. She was referred for a transcranial cross hearing aid. But this is an aidable hearing loss. So then instead of doing a transcranial assessment, she was rather assessed for a hearing aid, conventional hearing aid, but because she's got that normal ear on the right side, she does not meet the criteria here at Groote Hospital. Therefore, she was then referred to an NGO where they can assist with a conventional hearing aid at an affordable price. So that is basically the end of my talk. Thank you so much once again for listening. And like I said, this is honestly just to with provide you with as much information with regards to our bone conduction hearing devices, what we have here at Groote, so that when you are sitting with potential patients who can be candidates for any of these devices, you know how to refer, you have the information, and you're able to make informed referrals, and yeah, make also the patient aware of what the potential process that they're going to be going through. Any questions, comments?
Thanks, Yanela. That was a lovely talk and very nice cases, very insightful for us and the team. I'll put it to the
Thank you.
floor if anyone has any comments.
Thanks, Yanela. I think it's quite an important presentation for the registrars to avoid, or at least to make them refer appropriately, and also just to realize that there's a whole process involved. It's not just unilateral hearing loss, open to get a bar. There's actually a lot of discussion, much like an MDT that we do once a month on a Wednesday. And so if the ears are discharging, can we get the ears dry first before we go to implantable? Is it aidable or not? Based on the speech discrimination score and the SRT. So all of that. And I think it's quite important that they understand that there's a process rather than just, oh, maybe it's a bone bridge. Maybe it is a very academic discussion and a multidisciplinary team approach with the audiologist and an otologist to see what can be done surgically in terms of just a pure otological procedure, or maybe a secular reconstruction, or maybe a meatoplasty to stop the ears from leaking or make the ears more aidable versus an implantable hearing aid. And then also for them to realize that, one, that an implantable device has got to be the last resort. And then it's very different in private, where you have all those options available, and as a patient, you can almost make the choice yourself. Medical aids are not going to fund it either. You need to motivate as an audiologist why this person can't get a conventional hearing aid. But essentially, if you have the money, you can ask for any device you want. But that's very different in state when you have very limited funding and you actually have to go through a process and kind of just choose your patients very appropriately. And obviously that the holistic management, the holistic approach is important, taking into account the patient's socioeconomic situation, because these devices need to be maintained. And even though it may not seem like a huge amount of money, it's a lot for the patient. And a lot of our patients just yesterday, I had 2 patients in the clinic who needed to be referred to a social worker for transport money back home. So they've obviously borrowed money to come to the hospital and had no way of getting home. So those things are important in the consideration. As tough as that may be, it does affect who you choose as a patient. So thanks very much. Just one last thing, just for people to realize that the percutaneous bahas, because of the skin complications, are now very much falling out of favor. And very few, even in developed worlds, very few of them are actually choosing percutaneous. In our setting, percutaneous was always not great because of the skin complications. You know, there's got to be a lot of hygiene. It's a bit like if you're not brushing your teeth regularly, you're not going to get a percutaneous baha. But now what's happened is that the maintenance of the percutaneous is actually more than the transcutaneous bahas. And so we're trying to work those out completely and just stick with the transcutaneous because they're cheaper and we've got less soft tissue and wound complications.
Yeah.
Lillian, I don't know if you have anything to add.
Okay, well, there doesn't seem to be any other questions from the participants on the meeting. So thanks again very much, Yunela. We'll see everyone again on Friday.
Thank you very much. Excellent.
Thank you so much. And if you're not sure of how to refer, please either discuss with Prof. Harris if she's in a clinic, or you're welcome to come and ask us, before you fill in that referral, if this is actually someone that should be referred to the bone conduction hearing program.
Thanks, bye.
Thank you.